Breast cancer is the most common cancer in women. It can have a variety of presentations, from the classic lump to a subtle change in shape or texture. In this sketch, we're going to talk about a few risk factors associated with breast cancer, a few of the genes involved, and finally, the distinct types of breast cancer, each characterized by their unique histology and subtle differences in clinical presentation. Welcome to Cooper Family Farm's Summertime Farmers Market. See, the Cooper family is just different. They're all about organic farming, to an oversized extent. Just check out those huge turnips back there. Notice, too, that cancer crab bra on Mrs. Cooper, a recurring symbol for breast cancer. You gotta give it to the Coopers. They have a lot of pride when it comes to their produce. That #1 foam finger on Mrs. Cooper's hand isn't just because she thinks Cooper Family Farms is the best farm ever. It's also to remind you that breast cancer is the most common cancer in women. In the United States, breast cancer is the second most common cause of cancer death in women, second only to lung cancer. Worldwide, it's #1. So, what are the risk factors for breast cancer? Well, first of all, family history. Mutations in the BRCA family of genes, specifically BRCA1 or BRCA2, are a big deal. In fact, BRCA is literally a shorthand for breast cancer. Check out those two giant BRCA broccolis for sale under the Cooper Family Farms tent. One has a single floret for BRCA1, while the other has 2 florets for BRCA2. The BRCA family of genes are tumor suppressors, and mutations are inherited in an autosomal dominant fashion. See that recurring autosomal dominant domino holding up those amazing BRCA broccolis? Also, whenever we talk about tumor suppressor genes specifically, we symbolize the alleles with cancer-fighting ribbons. Now, with flawless florets like those broccolis were destined to win Best Broccoli 2 years in a row. You guys, that's almost 3 years in a row. See how one ribbon is already down? It's meant to remind you that BRCA mutations follow the 2-hit hypothesis. Cancer only occurs when both copies of the gene are broken. When individuals inherit a messed up BRCA1 or BRCA2 allele from their parents, they are much more likely to develop breast cancer since they only need to acquire one more random somatic mutation at some point in their lives to knock out that second allele. In addition to breast cancer, BRCA1 and 2 mutations increase the risk of epithelial ovarian cancers as well. Check out the ovarian cancer sketch for more details. Another important genetic risk factor for breast cancer is Li-Fraumeni syndrome. Just check out that table of giant award-winning gourds. They're all very interestingly shaped. There's a wrinkly old brain squash, a bony zucchini, a pair of breasty gourds, and a couple of triangular, adrenal-ish fruits. Let them remind you of the different tumors commonly acquired by patients with Li-Fraumeni syndrome. Li-Frau-many different tumors. Ha! Someone stayed up all night writing that. Li-Fraumeni syndrome is caused by a mutation in the p53 tumor suppressor gene. p53 is the classic cell cycle checkpoint gene, and at Sketchy, it's symbolized by a checkpoint gate. This time, it's broken by those gratuitous gourds. In case you hadn't noticed the autosomal dominant domino sign above that giant squash, Li-Fraumeni is also inherited in an autosomal dominant fashion. Another risk factor for breast cancer is prolonged exposure to exogenous estrogen after menopause, such as in hormone replacement therapy. Take a look at Mrs. Cooper. She's got a ton of jewelry on now, all of which are shaped like our recurring symbol for estrogen. She's smack dab in the middle of a pause during a commercial for the official fertilizer of Cooper Family Farms, EstroGrow. Unlike endometrial cancer, the risk for breast cancer is elevated even if progesterone is given along with estrogen. Check out our uterine gardening sketch for more details on endometrial cancer. Interestingly, OCP use does not increase the risk for breast cancer, suggesting that exogenous estrogen exposure prior to menopause doesn't carry the same risk. Of course, whenever increased estrogen is a risk factor, obesity follows closely along. Obesity is also associated with increased risk of breast cancer due to adipose cells' ability to convert androstenedione to estrone with their endogenous aromatase. Other independent risk factors for breast cancer include early menarche, late menopause, nulliparity, and older age at first pregnancy. Looking to grow your own gigantic award-winning veggies? Well, you're in luck. That stand full of Cooper Family Farms certified seeds is guaranteed to get you that pink ribbon you're searching for. They're even categorized for your convenience. Early bloomers for early menarche, late deciduous for late menopause, and non-fruit-bearing for nulliparity. Don't wait for your first pregnancy. Buy now. We're not exactly sure why these factors increase the risk for breast cancer, but it's been proposed that full cellular differentiation, which occurs in breast glands as they prepare for milk production, i.e., during and after pregnancy, protects the breast from cancer development. Delays in this process, whether from late childbirth or no childbirth at all, prevent this from happening and increase the risk for cancer. It's not all bad news, though. Breastfeeding is actually protective against breast cancer, likely due to the same process of promoting full cellular differentiation we just described. That's why that new mom is clutching her baby to her breast to protect her from those gigantic falling gourds. Can't stop that maternal instinct. Regardless of the type of breast cancer, each has its own specific genetics, which can significantly impact treatment and prognosis. Common genetic variations in breast cancer cells include overexpression of 1. Progesterone receptors, 2. Estrogen receptors, or 3. The HER2/neu proto-oncogene, an EGF receptor. Each is depicted at the sample table. We've got a progesterone dome to preserve freshness, and that mother must be pretty hungry. She's holding on to her 2 newborns in one arm to get her hands on a slice. And thirdly, that toothpick she's using is a recurring sketchy symbol for estrogen, and should remind you of the estrogen receptors that are overexpressed in certain types of breast cancer. Better act quickly. Those 3 empty plates embody the feared triple-negative breast cancer genetic variation, in which none of those 3 receptors are overexpressed. Triple-negative breast cancer carries a much worse prognosis, primarily because we aren't able to use the medications that specifically target the receptors or gene products. Just like many other kinds of cancer, breast cancer often begins as a precursor to full-on carcinoma. Let's talk about the 2 precursors to breast cancer, known as carcinoma in situ. The first precursor is a ductal carcinoma in situ, or DCIS, which, not surprisingly, arises from breast ducts. Remember your breast anatomy. Ducts connect to breast lobules, where milk is made, to sinuses that drain to the nipple. And in this scene, we're going to represent the cross-section of the duct with the cross-section of a turnip. DCIS arises from terminal ductal cells, eventually taking the form of a mass of cells completely filling the lumen. Notice, too, that the inside of the turnip is all rotten. That's because DCIS often has prominent central necrosis. The one key feature to keep in mind is that DCIS does not invade the basement membrane. It stays in the duct, keeping that turnip skin intact. All the same, DCIS is a precursor to invasive ductal carcinoma, which is by far the most common type of breast cancer. DCIS rarely presents with a palpable mass. Instead, it produces microcalcification seen on mammogram, a special X-ray scan of the breasts, which is how it's usually detected. Hence the tiny white microcalcification-y spots on the turnip. Also, see the skull and crossbones on her t-shirt? Our recurring sketchy symbol for radiographic imaging should remind you that DCIS is most commonly diagnosed by mammography. In fact, due to the widespread use of screening mammograms, diagnosis of DCIS has increased significantly over the past few decades. Treatment for DCIS primarily involves surgery, sometimes tailored endocrine modulating therapy, such as tamoxifen or anastrozole, is used based on the specific genetic variations of the tumor. We'll get back to that thought a little bit later. Fortunately, the prognosis for DCIS is very good. If properly treated, there's a low risk of recurrence or progression to invasive cancer. After all, if you've diagnosed DCIS, it means you've caught the breast cancer before it's invaded any other areas. Moving on, let's talk about the other major breast cancer precursor, lobular carcinoma in situ. Alright, if the turnip root is the duct, then the leaves are the lobule. Lobular carcinoma in situ, or LCIS, technically arises from the terminal ductal cells. But this time, the neoplastic cells head in the other direction and fill up the lobular space. On histology, LCIS contains cells with dark, round nuclei in clusters within the affected lobules. In contrast to DCIS, LCIS is relatively rare. It's still a carcinoma, though. LCIS confers a high risk of progression to invasive lobular carcinoma and ductal carcinoma. One of the reasons LCIS is so rarely diagnosed is because it neither produces a palpable mass on exam nor calcifications on imaging. Therefore, the only real way to diagnose LCIS is when you get lucky and see it on breast biopsy performed for some other reason. Treatment of LCIS is nearly identical to that for DCIS. Surgical excision, and sometimes specific endocrine modulating therapy depending on the genetic variations of the tumor. That's all for the precursors of breast cancer. Let's get on to the main course, the malignancies themselves. There are many different types of invasive breast carcinoma, but we'll start with the most common, invasive ductal carcinoma. Invasive ductal carcinoma evolves from DCIS, meaning we're now talking about a cancer that's broken through the basement membrane of breast ducts, just like that kid breaking through the side of the turnip. He also happens to be wearing a crab on his t-shirt, our recurring sketchy symbol for malignancy. The term invasive ductal carcinoma is also used to describe any breast cancer that can't be classified into one of the other types. That's one of the reasons invasive ductal carcinoma is the number one most common type, comprising up to 80% of all breast cancers. Clinically, invasive ductal carcinoma often presents as a painless, fixed, aka non-mobile, hard breast mass with irregular borders, most commonly found in the upper outer quadrant, just like that huge spiculated summer squash, breaking that wagon it's sitting on. Also, check out the skin of the squash. It's all dimply. And its top is all cratered inward, too. That's to remind you to look out for skin dimpling or inverted nipples. This phenomenon occurs due to tumor infiltration into the suspensory, aka Cooper's ligaments, which causes them to fibrose and shorten and pull the skin inward. When a mass isn't detectable on physical exam, breast cancer can be detected on radiographic imaging, typically via mammogram or ultrasound. See that sun and stars pattern on the woman's skirt under the mammogram skull and X-bones? The classic radiographic findings of invasive ductal carcinoma include a spiculated, aka spiky, just like the rays emanating from that sun, soft tissue mass and clustered microcalcifications, like all those tiny stars. See that glandular stuff coming out? On histology, invasive ductal carcinoma can appear as cords and nests of glandular, duct-like cancer cells. Just look for those dark purple, weird-looking hypercellular ducts. There will also be a dense desmoplastic reaction in the surrounding stroma. That's the collagenous pink stuff in between. And that's what makes the mass hard. As with many other types of cancer, the less differentiated the cells look, the more advanced the carcinoma. Alright, as you might have guessed, if there's an invasive ductal carcinoma, there must be an invasive lobular version too. Invasive lobular carcinoma is the second most common type of invasive breast cancer after invasive ductal carcinoma. Most present as a palpable mass lesion and density on mammogram. However, unlike invasive ductal carcinoma, some invasive lobular carcinomas do not present with an overt mass lesion, making it much more insidious than invasive ductal carcinoma. Check out that girl playing with those two huge lobular leaves emanating from the top of that turnip, scattering some smaller leaves in the process. In contrast to ductal carcinomas, lobular carcinomas are also more likely to be bilateral and present with multiple tumors. On histology, the classic finding of invasive lobular carcinoma is orderly rows of cells arranged in single file, as depicted by those surprisingly courteous children standing in an orderly single file line. For our next type of breast cancer, let's head over to the fruit section. That absurdly large blood orange represents so-called inflammatory breast cancer. Inflammatory breast cancer is an aggressive form of locally advanced breast cancer. The most characteristic finding is peau d'orange, an erythematous, thickened, and dimpled appearance of the skin overlying the affected breast. That orange peel appearance of the breast is caused by lymphedema, which results when the tumor invades the dermal lymphatic system, blocking the drainage of those lymphatic vessels and causing swelling and inflammation. With those stereotypical symptoms of inflammation, it's no surprise that inflammatory breast cancer is often mistaken for simple mastitis. When antibiotics don't do the trick, however, cancer should be high on your differential. The classic histologic finding in inflammatory breast cancer is dermal lymphatic invasion by poorly differentiated tumor cells. Cancer cells in the lymphatics? That's never a good thing. This phenomenon is the reason why inflammatory breast cancer metastasizes early and has a poor prognosis. Okay, moving on. The next three types of breast cancer are united by the fact that they're quite rare and come with relatively favorable prognoses compared to the other types of breast cancers we've covered so far. With that in mind, let's quickly review the distinguishing features of these cancers, starting with medullary carcinoma. To symbolize medullary carcinoma, we've drawn in the sign for the farmer's market, the mid-July farmer's market. On histology, medullary carcinomas contain sheets of poorly differentiated anaplastic cells with a significant lymphocytic infiltrate, all those little blue nuclei, kind of like all those blue hats in the crowd of people pouring in. Our next type of breast cancer, mucinous, aka colloid carcinoma, is even more rare, accounting for only 1% of all breast cancers. Mucinous carcinoma cells produce lots of mucin, surprise, which can spread into the surrounding stroma and produce soft, gelatinous, well-circumscribed masses, kind of like our soft, cuddly, and well-circumscribed little visitor over here. On histology, the classic finding of mucinous carcinomas are nests of tumor cells dispersed in large pools of extracellular mucus. The dog's owner represents another rare form of breast cancer, tubular carcinoma. Tubular carcinomas used to be super rare because they often form small masses that are difficult to palpate on physical exam. However, with the advent of routine screening mammograms, diagnosis of tubular carcinomas has increased simply because we're able to find them more often. On histology, tubular carcinomas appear as well-formed tubules infiltrating the stroma. symbolized here by those giant tubular green onions. Because tubular carcinoma cells are cytologically low grade, the prognosis for patients is excellent. Let's finish up with one last super interesting presentation of breast cancer: Paget disease of the breast. In Paget disease, malignant cells spread from an underlying carcinoma through the lactiferous ducts and into the contiguous skin of the nipple without crossing the basement membrane. In other words, think of Paget disease as a special DCIS extension of the underlying invasive carcinoma. Look for an ulcerated eczematous skin lesion that begins on the nipple and spreads to the areola. Just like this ulcerated eczematous leaf extending out from the stem of this Paget passion fruit. On histology, you'll see the eponymous Paget cells, malignant intraepithelial adenocarcinoma cells occurring within the epidermis of the nipple. These cells are large, full of clear cytoplasm, and contain dark, high-grade nuclei, just like those Paget's passion fruit seeds, invading the epidermal dirt. Interestingly, Paget disease can also present on or near the genitals, most commonly on the vulva. This is called extramammary Paget's and looks virtually identical to Paget's disease of the breast. Unlike Paget's disease of the breast, however, extramammary Paget's disease is less likely to be associated with an underlying malignancy, which is why the girl with the Paget passion fruit seeds on her lap is so carefree. Well, now that we've talked about the various types of breast cancer, how do we treat what we find? Treatment for invasive breast cancer, much like DCIS, starts with surgery and can include a number of adjuvant therapies, including radiation and chemotherapy. One specific method of treatment to point out is the use of selective estrogen receptor modulators, aka SERMs. These medications bind to estrogen receptors and activate or inhibit their action, depending on the specific organ that it's working on. In the breast, both tamoxifen and raloxifene have inhibitory effects on estrogen receptors, making them excellent choices for breast cancers that overexpress estrogen receptors. One thing to remember about tamoxifen, though, is that it has agonist activity on estrogen receptors in the uterus, increasing the risk for endometrial cancer. That's why raloxifene is preferred over tamoxifen in younger patients with breast cancer who want to pursue pregnancy. Recall that over in our uterine garden sketch, tamoxifen was symbolized by that TM on the estrogen canister, causing some unwanted proliferation of the uterine lining. Alright, let's finish up by briefly touching on breast cancer in men. Because hey, men can get breast cancer too. Breast cancer in men is super rare. It only happens once for every 100 cases of breast cancer diagnosed in women. When it does occur, it's most commonly in a man with a BRCA2 mutation, and BRCA2 only. Hence the Cooper family farmer father with his arm proudly around that BRCA2 broccoli. Breast cancer in men is typically more advanced by the time they're diagnosed, due in part to a lack of screening and awareness of breast cancer in men. Otherwise, breast cancer functions in men the exact same way it does in women. Alright, let's do a quick sum up of the varieties of giant veggies we encountered at the market, starting with the non-invasive malignancies. DCIS, microcalcifications on mammogram, central necrosis, precursor to invasive ductal carcinoma. LCIS, usually an incidental finding, round nuclei and clusters, can lead to invasive lobular or ductal carcinoma. Moving on to invasive. Invasive ductal carcinoma, the most common, tubules with well-differentiated cells, presents with a firm, irregular, immobile mass in the upper outer quadrant of the breast, with dimpling and nipple retraction, spiculated appearance on mammography. Invasive lobular carcinoma, less common, cells arranged in single file, can present without a mass or bilaterally with multiple masses. Inflammatory carcinoma, peau d'orange, poorly differentiated. Medullary carcinoma, sheets of cells and a lymphocytic infiltrate. Colloid mucinous carcinoma, nests of tumor cells among pools of mucin. Tubular carcinoma, well-formed tubules infiltrating the stroma. And lastly, Paget's disease, erythema, crusting, oozing around the nipple, with Paget cells in the epidermis. An extension of DCIS from an underlying carcinoma. And that's a wrap on the female reproductive, genitourinary, and breast pathology. On to the men.